Welcome all. Today's presentation is about progesterone only injectable contraception. This is the clinical effectiveness unit guideline published in December 2014. We begin with our quote of Master MRCOG with concept oriented clarity. Okay, this topic is also very important from examination point of view. They'll ask you the questions about either progesterone only pill or injectable contraception or implant also they can ask you. Okay, now coming to the progesterone only injectable, what is the mode of action and effectiveness? So primary mechanism of action of progesterone only injectable is it inhibits the ovulation. That is the main mode of action. And additional mechanisms are it will thicken the cervical mucus, making it difficult for the sperm to penetrate. Effect on mucus develops within few days but may take up to 7 days in some women. Endometrial changes make implantation less likely. So these are the additional mechanisms by which the progesterone only injectable will act. Now starting precautions. If started after 5 days of the cycle, use additional contraception for 7 days. We have seen progesterone only pill. They used to show its action within 2 days on the cervical mucus. While here it takes 7 days. And if it is started after 5 days, then additional contraception is required for 7 days to allow full effect. Okay, now effectiveness. Depot-metroxyprogesterone failure rate is 0.1 to 0.67% per year in the studies, while net N is failure rate is around 0.4% per year. Cumulative pregnancy rate is around less than 0.4, that is 4 per 1000. Now, if this injectable is compared with the other methods, the effectiveness is similar to copper IUD or implant when used correctly. What about the failure rate? With perfect use, it is 0.22 per 100 women years. Okay, the typical failure rate is around 6% due to missed or delayed injections. So this typical failure rate you should remember. And in our first lecture, I have shown you the chart of all contraceptive and their failure rate. Okay, the cost effectiveness, it is less effective than the implant, copper IUD or LNG IUS due to frequent dosing. Okay, so see, implant is acting for 3 years. Copper IUD, it has got a variable duration depending upon the which type of IUD. LNG IUS for 5 years. Okay, and then while here it requires a frequent dosing. That is why it is less cost effective. Okay, and it is more cost effective than the combined oral contraception after 1 year of use. Okay. So what is about the effectiveness? Perfect user failure rate is 0.2% in the first year, while typical failure rate is around 6%. So these particular values you should remember. Perfect is around 0.2% for injectables and 6% for the typical users. Then guideline follow up to date UK medical eligibility criteria for progesterone only injectables. Menstrual effects, amenorrhea or reduced bleeding is more common. It may benefit with menstrual problems, and bleeding pattern changes should be discussed with the users. So the bleeding pattern changes are very common with the progesterone only injectables, and those should be discussed with the patients before administration. Okay, now what are the therapeutic benefits? It reduces the endometriosis related pain, safe for sickle cell disease, may lessen crisis pain, protective effect against the ovarian and endometrial cancers. Okay, so these are the therapeutic benefits of progesterone only injectables. Okay, now what is the effect on the bone health? Now here there is a little risk. Okay, remember when you are using the injectable, bone health, it has got a little detrimental effect. It is associated with a small but reversible loss of bone mineral density for women less than 18 years, use only after considering the alternative. So it is not suitable for less than 18 years. It can be used provided alternatives have given the option also given and they are not suitable. Okay, then follow up and duration. Review every 2 hours for ongoing users. Switch at the age of 50 or continue after individual risk benefit discussion. Okay, so it can be continued up to 50, but you will have to switch after the age of 50. Then cancer risk, there is a weak association with the breast cancer. Small risk reduces after stopping. There is a weak link with the cervical cancer. If you use for more than or equal to 5 years, it declines after stopping. There is no proven association with the venous thrombosis, myocardial infarction, or the stroke. Generally, when we are using hormonal contraception, we will think about venous thrombosis or myocardial infarction, stroke. So there is no proven association with the progesterone only injectables. Now, cervical screening and HPV. Ensure cervical cytology and HPV vaccinations are up to date. Educate about the HPV prevention, condom use, smoking cessation, regular screening, vaccination, etc. Weight gain. There is a possible weight gain, especially in a less than 18 years with BMI of more than 30 or equal to 30 kg per meter square. If the woman is getting more than 5% body weight in the first 6 months, generally they will continue to gain the weight. This is very peculiar about this. If they gain the weight more than 5% in the first 6 months, generally these are the women who will continue to gain the weight. Okay. Now, about the injection site reactions, they are more common after the subcutaneous injection than after the intramuscular injection. So there are two types of DMPA. You can give subcutaneously also, you can give intramuscularly also. But the injection reactions are more common with the subcutaneous rather than intramuscular. Possible side effects are reported but not proven. They are acne, mood swings, headache, decreased libido, hot flushes, vaginitis. Administration sites are intramuscular. DMPA is given in the gluteal region, that is the preferred. So this is also one of the SBA which is frequently asked. So what is the site of IM DMPA? It is the gluteal region which is preferred. Another one is a deltoid muscle. Okay, in women with a deep gluteal fat, use deltoid or subcutaneous route. Okay. The subcutaneous DMPA inject into the abdomen or anterior thigh. That is the site for subcutaneous DMPA. Their injection schedule, concentrate here how frequently the injections are to be given. Okay, repeat every 3 weekly, every 13 weekly for IM or subcutaneous DMPA. It can be up to 7 days late. That means up to 14 weeks total without extra precautions. Okay, early repeat can be done at 10 weeks onwards, or in cases of NET-N, 6 weeks onwards. Okay. So they recommend it 13 weeks for IM or subcutaneous DMPA, but it can be up to 7 days late. That means up to 14 weeks in total. Okay, this I will discuss further in the next slide. Okay, drug interactions. Enzyme-inducing drugs do not reduce efficacy of the DMPA. So if the patient is on enzyme-inducing drug, we have already seen before about the enzyme-inducing drug, but this progesterone-only injectables, they do not reduce the efficacy. The drug does not reduce the efficacy of the DMPA. Okay, body weight and efficacy. No evidence of reduced efficacy in women who have a BMI more than 40, though the data is limited. So BMI more than 40, again, there is no limited data about reduced efficacy. There is no evidence. Okay, then stopping the DMPA. If stopping and not planning pregnancy, start another method before the next injection is due, and return of fertility may take up to 1 year. Okay, once the DMPA is stopped, it may take up to 1 year for the fertility to return. Then STI protection. Condoms recommended to prevent STI or HIV transmission. There is no clear causal link between the DMPA and HIV risk. Okay. Then unscheduled bleeding management. Most of the patients will have unscheduled bleeding. So there are two ways by which you can manage this unscheduled bleeding. The first option is use COC for 3 months. That means the patient is getting double contraception. You are giving this injectable progesterone that is causing the bleeding issues. So you start her on combined oral contraceptive for 3 months. Okay, either cyclically you can use, or you can use continuously. The other option is to go ahead with the mefenamic acid 500 milligram TDS for 5 days. Okay, so this is also going to be one of the treatment for the irregular bleeding. Okay, now what about the UKMEC categories? If the patient is having the history of VTE or non-thrombogenic mutation, in that particular case, progesterone only injectable is UKMEC 2, while SLE with positive or unknown antiphospholipid antibodies, it is UKMEC 3. Okay, If what is the effect on the lipid and cholesterol? Generally, there is it is not specifically categorized, but the good cholesterol, that is HDL, is reduced while LDL is increased. Okay, but level generally return to baseline within 24 months. So within 2 years, generally the this lipid profile becomes normal. What is the early effect? Early effect, the good cholesterol, that is HDL, will be reduced while LDL will be increased. But this effect comes to normal by around 24 weeks. Then what is the effect on myocardial infarction and stroke? If there is a history of this, in that particular case, it is considered as a UKMEC 3. So these UKMEC criteria you remember with respect to these conditions, because this can be asked as a SBA. Okay. So this VT is a 2, while SLE and myocardial infarction, stroke, current or past history will UKMEC 3. Now, what does this particular chart says? This is about progesterone only injectable contraception. Okay, advice on starting. How to start this progesterone only contraception? Up to 5 days, there will be no need of the additional contraception. Okay, after 5 days, there will be need for the contraception for 7 days. We have seen it was for 2 days for progesterone only pill, while here it is for 7 days. Okay, and if there is a risk of pregnancy, then emergency contraception and quick starting will be required. And for women who are amenorrheic, we have already seen if there has been a risk of pregnancy, then EC will be required and quick starting new. Okay, at any time it can be started, but additional precautions will be required for 7 days. Okay, then postpartum, up to 21 days, nothing is required. After 21 days, if the menstrual cycles are returned, then it can be started as like any other woman. Okay, if there has been a risk of pregnancy, consider EC and quick starting. After 21 days, if the menstrual cycles have not returned, then additional precautions are required for 7 days. If there is a risk of pregnancy, then emergency contraception and quick starting is required. Then first and second trimester, up to 5 days, nothing is required. But at any time after that, additional precautions will be required for 7 days. Okay. So this is how the progesterone only injectable is started. Then when switching from another contraception to progesterone only injectable, so if she is shifting from combined hormonal contraception to the progesterone only injectable, up to 2 days of HFI, nothing is required. Then day 3 to day 7 of HFI or first week following the HFI, additional precautions are required for 7 days. Okay, if UPC has occurred after third day of HFI, advise continuing the CSC method for at least 7 days. The same advice as we have seen for POPs. Okay, and if it is a week 2 or week 3, we know that if we are shifting, that means week 1 we have taken, she has used CSC well, so the ovulation is inhibited for the next 7 days, so she does not require additional contraceptive. Okay, then if she is shifting from traditional POP, then she can start anytime, but additional precautions are required for 7 days. If you see in the last 7 days, retain LNG IUS for 7 days after starting injectable. Okay. If she is using traditional POP or LNG IUS. Okay. Then switching from desogestrel POP, which is taken correctly, or progesterone only implant, in that particular case, it can be started anytime, but there is no need for the additional contraception. So desogestrel POP, because it causes inhibition of the ovulation, and progesterone only implant, which is within the active duration, she does not require additional contraception. More than 3 years since the implant, yes, in that particular case, additional precautions will be required for 7 days. And switching from copper IUD, for first 5 days, nothing is required at any time. 7 days of protection is required, so she will keep the retain the IUD for 7 days. Okay. Now, this particular, if she is using DMPA and she is shifting, or if she is using NET, DMPA can be given repeat doses up to 14 weeks and net in up to 10 days. And within that, if she wants to start injectable, she can start without any additional precaution. Okay. But if she is starting after 14 days and 14 days, after 14 days means even if it is a 1 day, in that particular case, she will have to use additional precautions. Okay. There are no UPSI, then there is no risk of pregnancy. She can start, but the additional precautions are required for 7 days. Okay. Same thing is with the net N also. Okay. In that particular case, she will require additional precaution. However, if there is a UPSI, then you may have to think about the EC also. Okay. If there is a UPSI, in that particular case, the EC will be required. So repeat injection. Here is the one particular thing, as SBA can be asked on this, when the repeat injections are required. So standard dosing interval as per the SPC. SPC is a summary of product. So whatever the information leaflet comes along with this, it says that IM DMPA is to be given every 12 weeks. Subcutaneous DMPA is given every 13 weeks and net N is given every 8 weeks. Okay, this is as per the SPC. But what does the FSRH guidance says, that we will see now. Okay. Now, what is the effectiveness? The failure rate we have seen, it is less than 4 per 1000 over a period of 2 years. Okay. So this is what we have already seen the effectiveness in the beginning. Now, let us talk about the repeat injection as per the FSRH guideline. DMPA up to 14 weeks can be given and net N up to 10 weeks from the last injection. This is as per the FSRH guidance. Okay. So we have initially mentioned about 13 weeks and 1 week late. So up to 14 weeks DMPA can be given. While the SPC says if it is a subcutaneous DMPA, give every 13 days. If it is a IM DMPA, give every 12 weeks. So please read the question carefully what you have been asked. Generally, it is the FSRH guidance is to be followed and DMPA can be used every 14 days. But by any chance, as per the SPC, if they ask, then these are the answers. Okay. Then WHO allows injectables up to 16 weeks after the last injection. Efficacy is maintained as per the WHO. Okay. So guideline group recommendation 13-week interval for both IM and subcutaneous DMPA outside the product license for consistency. So there are different periods of validity they have given, but the FSRH says 14 weeks. As per the SPC, IM DMP is 12 weeks, subcutaneous is 13 weeks, and guideline group recommendation is 13-week interval for both. Okay, IM as well as by subcutaneous, and WHO says up to 16 weeks. Okay. Now, unknown last injection and the pregnancy risk. If timing of previous injection is not known, give injection if reasonably certain that woman is not pregnant. Advise additional contraception or abstinence for 7 days. If pregnancy risk exists, then emergency contraception, a bridging method, or quick start. Pregnancy test is advised 3 weeks after the last unprotected sexual intercourse. Okay, so that finishes the topic of progesterone only injectables.